When I talk to a primary care audience, including myself, the most difficult topic that they tell me about is trying to interpret what the urine drug test actually shows. And this is a complicated topic. How long does the drug stay in the system? What is the metabolites that get involved in it? What are other contaminating factors, if they're eating food, for example, that may also show up in the urine? There's a whole variety of topics that make this a difficult topic, but today we're going to make this easy for you because we're going to kind of make it into categories that is easy for you to understand. Just like a hemoglobin A1C, you didn't know what it was to begin with, but now you do, and you know how to interpret different levels, and you make clinical judgments based upon those levels. So we're going to start first upon detection time. How long does a drug stay in the urine, and what do you do with that when you get that result? I'm going to start here with Dr. Clark, and how long do we have with these drugs in the urine?
Well, so obviously there are a number of different agents that we're interested in, and all of them have their own individual clearance, their own types of metabolism, and a variety of factors that will influence that. If we look at this first slide, amphetamines, for example, very short retention time. Will be cleared from the urine probably within 48 hours. In contrast, barbiturates, there's some heterogeneity there. Depending on the specific barbiturate that the person may be using, it may be that, for example, with secobarbital, it's only 24 hours. But a longer acting agent like phenobarbital might be there for several weeks, particularly if the patient is taking it chronically. Benzodiazepines, again, can tend to be shorter in their duration of retention, but might be there for several weeks at a time. So you can begin to see with this kind of variability, you can't just look at the date of testing, the date of prescription, the dose, the route, those important factors, and determine right away whether this is a true positive, false positive, etc. Cannabinoids are, again, and particularly for people that are using them on a chronic basis, really can be positive in the urine for over a month. And so that can become problematic if you're expecting someone to stop and you're doing follow-up screens looking for it to turn negative. They may have stopped quite a while ago, and they may be trying to comply with your recommendation, but you're constantly going back accusing them of being a continuous user. Not a good scenario.
So that patient that's using marijuana chronically, and you have them come in the next week to get it checked again, they'll still be positive.
They'll still be positive. Cocaine, again, relatively short period of time, a matter of days. The same is true of alcohol. Methadone, just like cannabinoids, much likely to hang around for a long period of time, particularly in the chronic user. Opioids, in contrast, again, a matter of a few days, maybe a week. PCP, again, approximately a week, maybe longer in chronic users. Propoxyphene, a medicine that we'd recommend that you not prescribe, but yet a relatively short half-life agent, and it will be gone very quickly. So I just can't make the point enough to say that these are not absolutes. They're relative values, and the context is important.
Thank you very much, Dr. Clark. Howard, I'm going to turn to you now and ask, it's important how you collect the urine, how to interpret the result when you get it back. Could you give us just some guidance on that particular topic?
Absolutely. I believe you improve the reliability of testing right from the beginning when the patient urinates or micturates in the cup. You want to tell the patient to immediately take the cup and put it on the collecting table from the bathroom before they wash their hands, and I will tell you why. As soon as they put the cup on the table, you want somebody, either yourself or your designate, to look at the color of the urine, because the color relates to the concentration of the constituents. Does it look like urine? A valid sample is 30 milliliters or more in order to do an appropriate urine drug test. Most labs and point-of-care testing have temperature strips on them, and within 4 minutes of voiding, the temperature should be between 90 and 100 degrees Fahrenheit. That's why I want the cup placed immediately on the collecting table. When the lab results come back, before you even look what drug is present or what drug is not present, look at the pH. It should be between 4.5 and 8. And also, you have to look at the urinary creatinine. The most common way to try to beat a drug test is by water loading. And urinary creatinine varies with water intake and hydration. Normal concentration is greater than 20 milligrams per deciliter. Less than 20 milligrams per deciliter is dilute, and less than 5 milligrams is not consistent with human urine.
Howard, I want to go back to that one point about temperature. So if the patient's getting urine from somebody else and they're keeping it in a bag in their pocket, it may not be the right temperature because it's been outside of the body for a period of time.
Absolutely.
So that's one of the reasons temperature could be important, or if they're taking their urine and diluting it with water, not water loading themselves, but just putting it in the cup. I've had several patients get around the urine test by just putting water in there, and that'll be colder and it will also be diluter, namely the specific gravity should be less and the creatinine should be less. So there's a couple reasons how it can get adulterated pretty easily, and unless you're observing it, you wouldn't even know.
Well, the point is that's why you want at least 30 cc's of urine so that it holds that temperature from 90 to 100 degrees Fahrenheit for 4 minutes.
Right.
And that's the importance of placing the cup immediately before you do anything else, and it's looked at immediately in order to ensure the reliability that the urine is what it should be in that particular patient. So let's go on again for the reasons for a positive urine toxicology. Obviously, there could be a legally prescribed medication. There could be ingestion of an illicit substance. Even the over-the-counter medication could cause a positive urine toxicology, such as desoxyephedrine in Vicks nasal inhaler will cause a positive for methamphetamine. Ingestion of foodstuffs such as poppy seed that could produce a positive urine drug test for morphine, or even lab errors. The point being is what I do before I do a urine drug test or before I really write the first prescription of the patient for chronic pain, I tell them, if you like bagels, don't eat poppy seed bagels, switch to sesame bagels. Have a list of all the medications that the patient's on that you prescribe or anybody on the planet Earth prescribes to that patient, and have the patient be instructed to tell you if they take any over-the-counter products. What are the reasons for a negative urine toxicology? Well, the collection concentration was below the threshold limit. That's called the lower limit of detectability. And the lab has a detectable level which will call positive and which will call negative. 300 nanograms per deciliter is positive, 299 is negative. That's why if you have an unexpected negative urine, you want to call the lab and get that information. Is it present or is it not? Also, a reason for a negative urine could be binging, running out of the prescription early. But there could be other more benign reasons for running out of the medicines early or not having it. Maybe the patient only had half the prescription dispensed by the pharmacy because they couldn't afford the full prescription. Either they didn't have insurance, had poor insurance, or were in the donut hole of Medicare. Obviously, diverting the medication could be a reason for a true negative urine toxicology. The key, what I'm saying, of the reasons for a negative urine toxicology, it opens up a differential diagnosis, not a definitive diagnosis. And you have to go through the differential diagnosis with your patient and what is more likely to be present or not before you accuse the patient of aberrant behavior. As I travel around the country giving lectures about urine drug testing, a common question that is asked by me is that can you tell by the value of the urine drug concentration, which is nanograms per deciliter, if the patient is taking the medicine as prescribed? I want to emphasize as strongly as I can, do not use results to make specific determination if the patient is taking the medication as prescribed. Software and laboratory products have not been fully validated to give this information. Do not interpret urine drug testing beyond the current scientific knowledge. To do so would put your patient and you at medical legal risk.
That's a very important point, Howard. Thank you for bringing that up. I want to thank the panel very much for this interesting discussion.